understanding the current politics of payment reform gives an understanding of why the time is ripe for this kind of project. We ended the last talk stating that fundamental changes in the way surgeons are going to be paid are inevitable. We should stand on some principles for our orthopedic practice. We'd like to preserve as much autonomy for surgeons and patients as we can. We want to reward hard work for making a difference in our patients' lives. We want to improve the orthopedic evidence base so we can improve our subspecialty. We need to decrease any unwarranted volume, or at least justify the high value of the volume of services that we choose to provide. Finally, we need to welcome incentives that help doctors and patients select high-value care and be aware that there may be disincentives for low-value care. The financial threat to the economy is so great that both Democrats and Republicans have approached leadership in orthopedics asking for a solution and helping to change the way doctors get paid. Most physicians have very little experience with politics. Medical schools rarely discuss much politics, but the phrase I remember, a person who starts in medical training as a conservative is heartless, and a person who ends their medical practice as a liberal is brainless. But it doesn't really matter whether you're heartless or brainless. The PhD economists who are giving advice to the leaders of our country have stressed the importance of finding a better payment system for physicians. Physician leadership at CMS also agree that the #1 priority is testing new payment and care models to get our system on the right track. The Affordable Care Act has some major health insurance reforms, but there's also a section on a value-based payment modifier, which is a budget-neutral way to change the way doctors are paid for Medicare, and they're talking about measuring quality and costs.
We've estimated that most of this plan can be paid for by finding savings within the existing healthcare system, a system that is currently full of waste and abuse. The only thing this plan would eliminate is the hundreds of billions of dollars in waste and fraud, as well as unwarranted subsidies in Medicare that go to insurance companies.
The advisors to the executive branch, which most of us consider a liberal branch of government right now, are saying that the primary barrier to a greater use of system methods and tools is the predominant fee-for-service payment system, and that to change the system, the nation's going to need to move more quickly to payment models that pay for value rather than volume. They go on to say new payment models that depend on metrics to identify high-value care are needed, and they want strong quality measures that are based on outcomes. If that's the liberal view, we should give the conservatives a chance to speak as well.
There's a fundamental economic law which has never been contradicted to the best of my knowledge. And that is, if you pay more for something, there will tend to be more of that something available. If the amount you're willing to pay for anything goes up, somehow or other, somebody will supply more of that thing. We have made immoral behavior far more profitable. We have, in the course of the changes in our society, been establishing greater and greater incentives on people to behave in ways that most of us regard as immoral. On each of us separately, we've all been doing it.
Bob Moffett is a fellow at the Heritage Foundation, and he wrote this piece for National Affairs, How to Replace Obamacare. He notes that government spending on health care has surged, the tax collection has not kept pace, and that yields the primary driver of today's deficits and mounting debt. He says Medicare is terribly flawed because the program pays providers of care on the volume of their services. It creates a massive incentive for inefficiency and overuse. The program's dominant fee-for-service structure provides all the wrong incentives, and they recommend change. It doesn't matter whether you're on the right or on the left, everybody's saying the same things now. The system is going to change to where providers who give high-quality care at lower costs are going to be in a winning position. Since the payment system is changing, it's worth understanding the previous payment system. It was the SGR that came out of the 1997 Balanced Budget Act. It was a payment formula to try and limit the overall Medicare expense. It was an RVU-based formula where the conversion factor was altered by the GDP. A problem arose when the Medicare enrollment increased and the number of things we could do for the Medicare population increased, while the GDP was quite variable. The costs of doctor services rose faster than the GDP, and that led to a growing threatened payment cuts every year where Congress had to do doctor fixes to avoid a large change in the doctor's payments. This resulted in a huge waste of political capital, and nearly all medical groups, including MedPAC, several think tanks, and the Institute of Medicine, recommended reforming the SGR. But even before the SGR fix, Sylvia Burwell, the Secretary of the HHS, set long-term goals to improve the overall problem. Her goal was to tie 30% of traditional fee-for-service Medicare payments to quality or value and 50% of payments by the year 2018. So the plans to link fee-for-service Medicare to quality or other alternative payment models that incorporated quality and reduced costs was already established. The law to put these changes into position had already been submitted by a doctor legislator from Texas, Michael Burgess. He had previously submitted prior laws, but finally through H.R. 2, the Medicare Access and Chip Reauthorization Act, or MACRA, the SGR fix became law. MACRA creates a time period where there's stable but small increases, but then the value-based payment reforms kick in. It'll be through two main streams, either the merit-based incentive payments, which is MIPS, using the PQRS data, or alternate payment mechanisms like ACOs or bundled payments. This is where a qualified clinical data registry may fit in. For those not participating in alternate payment mechanisms, the MIPS provides an opportunity where they're going to measure quality, resource utilization, the clinical practice improvement activities, and meaningful use of your EHR, with growing incentives and disincentives over time. The quality domains for the value-based modifier include PQRS measures, and there are not many orthopedic-specific measures in the system. It also includes 3 other claim-based measures in the fee-for-service system for potentially avoidable diagnosis: the acute diagnosis of pneumonia, UTI, and dehydration, and then chronic conditions like diabetes, COPD, and congestive heart failure. Those are not very orthopedic-specific. They will measure a 30-day readmission, which orthopedics can control to some extent, and they're including CAHPS, the Consumer Assessment of Health Providers and Systems, which is a satisfaction survey. The example of the CAHPS, though, has 89 questions, and this is probably not a realistic survey for most of our patients. But a working incentive program is important for subspecialists as well. While we see only 40% of the visits, 70 to 80% of the money spent in the system is spent by the subspecialists. Most specialists have developed in a culture of fee-for-service where pay is related to how much work is done. Defining quality represents a risk because evidence-based measures are few. But the law also allows qualified clinical data registries to take the place of the PQRS requirements, and this would allow collecting metrics selected by orthopedic subspecialty societies and reporting those results in regional collaboratives. Providing local market feedback should create greater surgeon interest and stimulate greater change toward better outcomes. Coordinating the metrics and reporting between CMS, the ACGME, and the American Board of Orthopedic Surgeries could help relieve the administrative burden of academic programs and private practice when doctors are recertifying through the Maintenance of Certification program. Establishing the pattern of reporting early in training and tracking outcomes over the practice of a surgeon could help create the needed feedback required for true practice-based learning. A state-based value registry would help meet the recommended goals of government advisors who favor accelerating the transition to outcome-based payments, accelerate the development of a healthcare data infrastructure, and then provide provider-level cost data and quality data for both the Health and Human Services and the private insurers. It would provide a concrete way for HHS to support states' efforts to improve value. The registry would allow us to continue doing what's best for our patients by preserving the autonomy of what we can do for our patients, rewarding those doctors who really make a difference in their patients' lives. It allows a way to collect data that will improve the evidence base for our subspecialty, and by taking ownership of the definition of quality, we can help decrease any unwarranted volume while still using the new laws to allow orthopedic surgeons to harness incentives that increase value to society.